Hello, I'm Jocalyn Marchington. I'm Director of Global Operations at Caudex, and today I'm going to talk to you about a panel session I participated in at the recent ISMPP meeting, which is entitled Mythbusters, Separating Fact from Fiction in Our Profession. Quickly go through my disclosures. I'm presenting a whistle-stop tour of some other people's presentations, so they have been condensed significantly from their original form. So why did we decide to do this session at ISMPP? We needed a way to make people aware of the evidence that's out there supporting what we do and how we do it. I'm a member of the Global Alliance for Publication Professionals, GAP. We'd recently published a review article in Accountability and Research, which covered quite a lot of the issues around particularly ghostwriting. And we thought that might be a good basis for starting a session. So we thought about it a bit and then came up with 5 myths we thought would be worth tackling. The first 3 are around how we conduct our profession in terms of ghostwriting bias and medical writing support. And the last 2 a little bit more out there, one about the disclosure rate of clinical trial data, and one which you'll see when I come to it, damned if you do, damned if you don't, about disclosures. My co-presenters, you can see me. I feel fair to, I need to introduce my co-presenters, who are Karen Woolley and Santosh Mysore. Karen is from the MedComms group. She is a very outspoken advocate for what we do and very active in the Asia Pacific region. Santosh is a publications lead from GSK in Belgium, and they were presenting on behalf of the Mythbusters. We also had some evaluators around who we wanted to try and convince with the evidence that we were going to present that we were a good profession and we're acting ethically at all times. And our evaluators who were coming to the meeting were Jocalyn Clark and Richard Smith, both of whom are journal editors, either currently or of yore. And I would just say, if you ever get the chance to see Richard Smith present, take it. He's an excellent presenter. The setup, we decided it was the last session of the day. We wanted to make it interactive and interesting. So basically we gave each myth 5 minutes to get busted. So we had a 5-minute presentation with a hard stop, klaxon at the end, quite scary. And then the evaluators held up cards telling us whether they thought the myth was confirmed, plausible or busted in the style of the TV show Mythbusters. And then they had 3 minutes to explain why they'd given us the verdict they had. Although the evaluators knew what the myths were going to be, they hadn't seen the slides in advance. They didn't know the evidence they were being presented with. So really take my hat off to mention they responded on the fly. It was an interesting experience. So without further ado, I'm going to condense a 50-minute session into a much shorter presentation and go through some of the evidence that we presented. So, number 1, professional writers are ghosts. Now this was presented by Karen Woolley. Started out showing us that there are many ghostwriters in the world. Google will show you 6.5 million of them without trying very hard. And she also acknowledged that medical ghostwriting has taken place in the past and cited the Grassley report, which came out in 2010. But there's been a lot of confusion and conflation of the term ghostwriters and professional medical writers. And there's a link to a Monty Python video at the end, which will explain much better than I will how she got that conflation across to the audience. But it came down to the fact that ghostwriters and professional medical writers do the same thing, so they must be the same thing, right? No, wrong. So the initial evidence that Karen presented was from the Global Publication Survey, which was a membership survey run by ISMPP a few years ago. And ghostwriters and professional medical writers are mutually exclusive because of 2 things: disclosure and following professional and ethical guidelines. So professional medical writers disclose involvement and they follow the guidelines. And the evidence presented from the survey shows really high following of disclosures and routine use of guidelines such as GPP2, which was in force at the time, and ICMJE criteria. And there was a further sub-analysis that Karen and her team conducted, which shows that the certified medical publication professional was slightly more up on the routine use of guidelines and criteria than non-certified people. But basically, people who are professional medical writers are up on guidelines and up on disclosure. Now, anyone can claim to be a medical writer. It's not something you can get a degree in yet. But amongst the medical writing community, there's recent publications showing that ghostwriting is decreasing. The MWAR member survey, which is run by Cindy Hamilton and Adam Jacobs every 3 years, has just published its final report and has shown a 44% decrease in the prevalence of ghostwriting over the last 9 years, which is good. And professional medical writers are increasing, and that's shown by the membership of societies like ISMPP, MWAR, and by the number of certified medical publication professionals, which is now nearly 1,000. I couldn't resist showing this slide. This was a pretty crude search of Medline showing publications about ghostwriting. And you'll see there's a huge increase starting probably around the turn of the century. Can't really read the numbers on the slide. And peaking in 2012. Now, 2012 was the year that the Global Alliance of Publication Professionals was formed. And although you can't prove that correlation equals causation, it's nice to think that we're having an impact. So since we've been publishing articles refuting ghostwriting, explaining what we do, explaining how we do it, it appears that there is a decrease in the literature about ghostwriting. So we like to take the credit, but we can't, I don't think, prove that one statistically. Karen then relied on expert opinion, which is the lowest form of evidence, from academics and journal editor groups, all of whom say professional writers can be legitimate contributors to manuscripts. Position statements from industry say professional medical writers should be used. And the actions of the professional associations over the last 10, 12, 15 years have been actively fighting ghostwriting, and we're trying to educate about best practice. So, sadly, we didn't bust the myth. Our evaluators found the myth to be plausible, that medical writers are ghosts, congratulating us on our great progress in terms of disclosure, but pointed out that we don't have any control over people who aren't members, which is fair enough. And we have no way to measure non-disclosure. You can't measure a negative, it's very difficult. So although we were hoping for a busted, we were pretty satisfied with plausible, and we were so pleased we didn't get confirmed. So that was the first myth. The second myth, professional medical writers introduce bias. Again, Karen presented this one, and she very cleverly structured her argument around an article written by Richard Smith, which espoused that if you have a biased sponsor designing a biased trial using a biased writer, you have biased reporting. We can't do much about the sponsor in the trial because the writers enter the fray very late on. But if we introduce a professional medical writer, can we influence biased reporting? ISMAP and M1 and AMWA have similar clauses in their code of ethics, which is about ensuring accuracy, completeness and fair balance, authors' responsibilities, and about presenting data truly. So all the codes of ethics, the professional associations say we shouldn't introduce bias. Do medical writers introduce bias? There are two studies cited by Karen here, references you can have a look yourself. The first listed 12 outcomes from papers where the potential to introduce bias could be measured. And there were no significant differences between industry-sponsored and non-industry-sponsored manuscripts in this study. The assumption was that industry were more likely to use medical writers, therefore medical writers aren't introducing bias. A second study looked at 9 players, and that's the author's word, not ours, who could potentially introduce bias into an article, and of the 9 listed, professional medical writer was not one of them. Do medical writers commit misconduct? Karen pointed to some of her own research on retractions and pointing out that only a very, very small percentage of retractions for misconduct are papers that involve medical writers. Do medical writers reduce the risk of bias? Papers involving professional medical writers support are more compliant with consort, again shown by Adam Jacobs and the OPG team. But there's still room for improvement. We're not perfect, we're just a bit better than academics, it would appear. And also the MPIP initiative pointed out that journal editors recognise that professional writers raise reporting standards, improve compliance and increase overall quality. So, another accusation thrown around casually is that medical writers have to please the marketing departments. Now again, it's very rare these days for marketing departments to be involved in publications budgets. The GPS Global Publication Survey showed a 5% prevalence of marketers being involved in publications. And my take on that would be this is probably the smaller companies where people have to wear multiple hats, and there just isn't the headcount to separate marketing from publications. And funding source was not really a high concern for the co-editors at their meeting in Europe a couple of years ago either. However, again, we got a plausible from our evaluators who pointed out that medical writers aren't the only source of bias. Bias can be introduced by many other people, as almost evidenced by the paper that Karen cited. Again, not all medical writers follow the practices outlined, so again, we're harking back to the previous myth. And not up to date with guidelines. So we're a little bit disappointed with that one. I hope for a better outcome. So on to number 3. Now, This myth is around that researchers shouldn't need medical writing support. Santosh presented this one. And it was based quite heavily on the article I mentioned right at the beginning, the GAP article that was published in Accountability in Research. And we kind of looked at this mechanism about what do you need to be able to write publications. So publication guidelines knowledge, best practice reporting knowledge, time, which is very important, enjoying writing, which not everyone does, and English fluency, which is an increasing issue with our global remit for publication production. So just going through these. Can all researchers do these things? Poor adherence to reporting guidelines and incomplete data disclosure. Again, I can't go through the detail, I don't have time, but all these references are in that paper I mentioned earlier, and they're here for you to look up directly. This is all academic research showing that academic researchers have low adherence to guidelines and are complicit in data disclosure, mainly due to lack of time, to be honest. The review mentioned here asks about why haven't you published your conference abstracts as a full paper, and most of it is lack of time, some lack of interest, don't think it's that interesting kind of thing. Language fluency also is an issue potentially, and then Santosh presented some evidence from a couple of centres which have employed publication professionals within an academic centre, and it's improved the publication rate, not only in quantity but in the kind of journals and the kind of impact factors, the journals that they're publishing in. And lack of training has been cited. Researchers are trained to do research, they're not trained to describe or write up that research, and that is a sad fact presented in these two papers. So, final piece of evidence, authors familiar with professional medical writing support appreciate it. And these are two papers, one of which is from Santosh's group in GSK, and one was some member research that we presented at ISMPP a few years ago, surveying authors, and authors who work with medical writers quite like it. But did we bust it? We busted it. The editors were actually very appreciative of papers they receive that have had professional medical writing support because they're appropriately structured, the submissions process goes more smoothly, and the journal editors just like them. So we did get a busted, so we were quite happy with that result. So they're the three myths about ghostwriting and professional conduct, and the last two are a little bit different. Half of all clinical trials remain unpublished. Now this is one we don't normally go near, certainly as GAP, because as publication professionals we're not necessarily in control of data disclosure, but we thought we'd take a swing at it anyway. So we tackled this myth on three bases. The half, how can you quantify it? The all, what do you mean by all research? All trials. And unpublished, what does unpublished actually mean these days? Now, the All Trials campaign, who are the heaviest proponents of the 50% of all trials go unpublished statistic, rely quite heavily on a Cochrane review by Song, published in 2010, which was actually based on a previous Cochrane review by Song 10 years earlier. Neither of these Cochrane reviews make any attempt at all to estimate overall publication rates, so I really don't know where that 50% comes from. Also, the most recent study included in that was 2003, which I think is 13 years ago now. And the publication rates that are presented in the studies vary enormously, but so do the methodologies. So my argument would be that what are the studies you're looking at that report publication rates actually looking at? Now this has been dissected in great detail by Adam Jacobs. The links to his blog is on the slide there. But you're seeing studies recently, for example, of different funding sources, NIH funding sources, are they published, are they not? We're looking at specific drug classes in a specific time frame, were they published not? We're looking at drugs approved by the EMA in 2014, 2012, and the specific trials relating to those drugs, are they published, are they not? The numbers vary enormously, so apples and pears. It's very hard to hang a number and an all on any of this research. You also get some myth perpetuation, where research is miscited. This paper came out and everyone was jumping on it because it does actually say there's a 50% publication rate for these studies. But what they don't realise is that the studies that they're looking at a publication rate in journals from were 100% disclosed on clinicaltrials.gov. So actually there was a 100% disclosure rate for the data. Granted, only 50% of them are published, but as I said earlier, what does publication mean these days? There's also miscitation in research. This is the paper I was looking at that was looking at, I suppose you call it outcome switching these days, selective reporting. And the first line caught my eye, because about half of all randomised clinical trials had ever published. Didn't recognise the reference, so I went and read it. And actually it was a study of conference abstracts which then went on to become full publications, and it was 62%, which I think is nearer a third than a half. So I suggested perhaps rewriting this first sentence might be about a third of randomised clinical trials presented in abstract form up to 2003 were never published as a full journal article. Not quite as snappy, not quite a good soundbite, but a lot more accurate. And then the published part of this, the mechanism for data disclosures are manifest these days. There's publications, there's registries, the data request websites, there's Figshare. You can get your data out any way you like. So does publication in a journal, is that the only way to get clinical trial data out? So, didn't win. Evaluators found the myth to be plausible on the grounds that they couldn't actually quantify the statistic. So I kind of shot myself in the foot. It's plausible that the rate of disclosure is that low, although I'd argue I don't think it is. But they did acknowledge that academia and industry are equally bad at getting publications out from clinical trials. So, on to the last one. Damned if you do, damned if you don't. This isn't so much a myth as an unintended consequence. It's about disclosure and how we're getting adverse publicity, adverse stories about disclosure and medical writing support for papers and articles rejected without review of the medical writers involved. The damned if you don't part of the myth I have no qualms with. If you don't disclose, you should be damned. My argument is if you do disclose, you shouldn't be damned. So I looked at this in a couple of different buckets. Reader bias, first of all. Evidence, a paper published in New England Journal of Medicine had some fictional abstracts which were assessed for trial design, confidence in the results, and the willingness to change prescribing behaviour as a result of the abstract. The only difference in these abstracts, these fictional abstracts, which they had industry funding, NIH funding, or no funding. And industry funding dropped the rating on all parameters for these studies. So reader bias is evident from there. Anecdotally, Richard Lehman's BMJ blog, where he comments on articles published in other journals, was talking about an EJM article, and in the middle of the review of the article came up with this statement: how much of it was written by the authors is unclear. Medical writers paid by Bristol Myers Squibb. Well, yes, they were. We told you they were, and it was disclosed, and you're still not happy, so what are we supposed to do? And similarly, there was a MedPage Today article about, it was the First Amendment ruling on off-label promotion and the use of potential articles. Looked at one article, and again, there were industry authors, which they were criticised for. There was disclosures of funding for the non-industry authors, which they were criticised for. There was professional medical writing assistance declared, which they were criticised for. So disclosure equals dismissal in the eye of quite a lot of reporters. Reviewer bias, another study, a survey of peer reviewers, and inclusion of author disclosure of industry support increased the amount of time they spent reading the articles. It decreased the perceived credibility of the results, and in 40% of reviewers' cases affected the recommendation for publication. And that's just declaration of support. Another piece of member research, MISMAP, articles with disclosed medical writing support spend an additional 31 days in peer review, being delayed and being scrutinised more heavily. And anecdotally, rejection letter within 2 hours of submission. We only consider original papers written by the researchers with full disclosure of medical writing support, so that was very disappointing. Having said that, some editors are coming round to the idea that medical writers can disclose and can be involved and disclose fully. There was an article in one of the Nature journals, which was published, and there was some subsequent correspondence criticising the use of medical writing support. And the editor of the journal then, in the next issue, put out an editorial citing the World Association of Medical Editors guidance and pointing out that the best practice had been followed, and full disclosure to best practice and the journal's instructions to authors meant they were really very happy with accepting these kinds of articles, and disclosure should not be taken as damnation. However, at this point, I did throw in the towel, because though I said I think you should be damned if you don't disclose, I don't think we should be damned if you do. I actually asked the journal editors if they had any advice for us in terms of turning things around. So they did confirm the myth, they agreed. They did say that they thought peer reviewers should examine industry-sponsored work more closely, which I don't necessarily agree with. But they agreed that it was unfair that getting criticised for being open wasn't really going to encourage you to carry on doing it, but there was far more danger in not disclosing support, so carry on doing it, and maybe just momentum over the years will get us there. So those are the 5 myths. At the end of the session, we had an audience question asking the audience which of the 5 myths they thought we still need to work on. They weren't that worried about researchers needing medical writing support because that was a happily busted myth. I was quite surprised that the half of all clinical trials remain unpublished. They thought that they wanted us to provide more evidence about, because again, I said before, I don't think medical publication professionals are the only players here, and we're not the only guys who can influence that, but we can certainly help. And the other 3 myths were quite equally spread between the audience. So on that note, there are some links here I've mentioned throughout the presentation. I recommend the Monty Python clip. Supporting references for most of these which aren't in the article I mentioned at the beginning are on the GAP website. And thank you very much.